So what I've been discussing is that we are using genomic markers, biomarkers, and I would say that we are doing precision diagnostics. We really identify patients with high-risk disease using different technologies. And I would also argue that we have treatments that are directed to the Achilles heel of CLL. So we use B-cell receptor signaling inhibitors and BCL2 inhibitors. So it's also precision therapy. So I think it is fantastic for me that we are now going from the chemoimmunotherapy era into only using targeted therapy. But of course there are remaining challenges. We have different treatment options now, which is very good. We have different type of BTK inhibitors and BCL2 inhibitors. And there are open questions: should you give the treatment for a selected time period or continuously? And should you give them in a certain sequence to the patients? So there are both questions remaining, how you should sort of steer the treatment order for these patients. If they first respond and then get a relapse, what should you do then, and so on. So these are open questions, and hopefully we can use molecular technologies in order to understand, to predict which patient will respond well to therapy or is less suitable for a certain therapy. So I think that we have to always, when we do this, we introduce the new therapies and we do clinical studies, we have to in parallel do deep molecular profiling, because hopefully we will then learn which are the responders and non-responders, and we can develop predictive therapy, predictive markers that we then can start using in the clinic later on.